was 41.5 kilograms per meter square. She had an HbA1c of 6.2, was newly diagnosed to have diabetes, impaired fasting glucose, not on any medications, was just advised lifestyle changes. Blood pressure was normal, and she had borderline cholesterol levels, again just advised lifestyle changes, no medications as such, and the ultrasound of the liver was normal. Coincidentally, we had another similar patient. So just in short of summarize this patient, this is a 37-year-old lady with a morbid obesity and borderline metabolic problems. Another lady, 36-year-old, almost similar age, almost similar BMI, 43.08 kilograms per meter square. Although she was having florid diabetes, 1 week back she was diagnosed with diabetes, HbA1c was 9%. She started on lifestyle modification metformin before coming to us. So the last 1 week, she's already on to antihypertensive agents, and she had dyslipidemia. Ultrasound of the abdomen showed grade 2 fatty liver. So in short, a similar age lady, similar BMI, but vast differences in the metabolic profile. So we went ahead and did some body composition analysis for her. So this is actually done by a DEXA scan, and we compared the body composition results of these two patients. Look at the total body fat percentage in both the patients. Patient 1 had slightly higher total body fat percentage. When you look at the visceral fat, that was almost double as compared to patient 1. So at this point, any of these patients here, I'll come back to them later in the presentation. But with this background, I'm sure all of us are aware that the trends in obesity are rising. This is data from the Well-Birth cohort, one of the oldest birth cohorts in the country, where we saw that over the last decade or so, there was almost a doubling of the prevalence of obesity, especially in women, from 30% to 71%. And so even in men as well. There is data available from the US that similar patterns exist, but even those who are non-obese or so-called having a BMI less than 25 are also not spared. I'm sure all of us are aware of this paper that we Indians, even if we have a normal BMI, tend to have much more body fat, much more metabolic problems, and a lower BMI cutoff. This is we tried to qualify this further by one of our studies, the Kerala Diabetes Prevention Program, where when we looked at the prevalence of obesity, almost half the population was obese. But when we look at these normal weight people or so-called non-obese people, about 2/3 of them actually had high body fat, and these are people who are called as normal weight obese because they have normal BMI but higher body fat. When we look at the metabolic parameters of these patients, whether it is diabetes, hypertension, or dyslipidemia, all their values are almost similar to those who are obese, and the non-obese people are totally different, the ones who have normal fat. So even if we have a normal BMI, that doesn't mean that these people are not at risk for developing these metabolic complications. So with this background, and also when we go to cases that I presented, for the next few slides, I'll try and take you through these questions. What is ectopic fat and how is it formed? What are its metabolic consequences? And do the ethical differences that I showed you in the previous slides, does the difference in ectopic fat somewhat explain why we are so different? What is the message for a clinician? How do we assess ectopic fat, and what's the evidence behind the management strategies? So what is ectopic fat? Ectopic fat is nothing but fat which is present at the wrong places. There's this fat which is present around certain organs and certain confined spaces, which could be like the muscle. If it is present in the muscle, obviously the glucose uptake in the muscle is affected, and there is insulin resistance at the level of the muscle. Similarly, if it is present in the fat in the liver, it causes fatty liver, and that also kind of produces insulin resistance at the level of the liver. If it is present in the omentum, we call it visceral adipose tissue. Again, it's more important for inflammation, inflammatory cytokines that are produced from there. And of late, pancreas have actually also been included in this papers in 2011, but of late, is also an important place of ectopic fat deposition. There could be local fat deposition, that is essentially perivascular, pericardial, and these are the type of areas where it's essentially local lipotoxicity that we talk about, local inflammation and promotion of atherosclerosis. Even renal sinus fat tends to cause glomerulosclerosis and produces hypertension. So essentially, ectopic fat is nothing but fat which is present in the wrong places when it is not usually supposed to be present, and when it is present, then it causes metabolic problems. Why is it formed? So whenever we have a mismatch between our intake of calories and expenditure, and whenever there are excessive calories, initially whatever fat is formed is tried to be accommodated in the subcutaneous region. So if the fat is accommodated in the subcutaneous region, it's probably good, but how much of fat that can be accommodated there depends on the genes, the ethnicity, and the aging. And also some modifiable risk factors of living. Smoking is said to be somewhat responsible as to how much fat can be accommodated in the subcutaneous tissue. But once this fat store is full, there is a spillover of the fat, and that's when it starts to reach organs like liver, muscle, pancreas, perivascular fat. So this was one hypothesis. So whenever there is more calories, there is more fat, but also people who are inherently more insulin resistant, maybe it's because of the genetics or whatever, obesity, they tend to have more fat formation in the liver. So it could be either by intake of more calories or because of inherent or genetically determined insulin resistance that can contribute to this fatty liver. But to understand this concept of subcutaneous fat and visceral fat in a more simplistic way, I'm sure all of us have used pioglitazone, and we know that by using pioglitazone, even if the weight increases, there is a drop in the insulin resistance. So what happens when we use pioglitazone? The visceral fat actually comes down, whereas the subcutaneous fat gets more. And that's the reason even if the weight is increasing, these patients actually benefit and they have less insulin resistance. So even as visceral adipose tissue fat increases, there is reduced insulin sensitivity. Another example of trying to understand where this subcutaneous fat and visceral fat is important is more of a genetic phenotype. So this is a patient who presented to us at the age of around 27. She had diabetes, hypertriglyceridemia, a very acromegaloid kind of look that she had. And she had an inherited cause wherein there was no subcutaneous fat because of the liver dystrophy that she was having. And so when there is no subcutaneous fat, fat tends to spill over in other organs like liver, pancreas, and that's why they develop so bad insulin resistance. Later on, we did test and found this type 2 mutation, which explained this congenital dystrophy that she had and why the subcutaneous fat is important. So all said and done till now, we've seen that there is enough evidence that the subcutaneous fat is important, and if it is overwhelmed, whether we overwhelm it by using drugs or by genetic differences or just by increase in calories, it tends to get into the visceral fat and it causes metabolic problems. So how it causes metabolic problems? So we'll get to the pancreatic fat. So if there's more fat in the pancreas, we're talking more beta cell dysfunction, less insulin production. If it is intramuscular fat, less glucose uptake in the muscle, and therefore again more insulin resistance at the level of the muscle. If it's fatty liver, then again insulin resistance, oxidative stress, more cytokines, more inflammation. Again, visceral fat, again more adipocytokines which are inflammatory, and that causes again metabolic syndrome. The local effects of these fat, whether it is perivascular or perisinal fat of the kidney, it also causes metabolic problems and ultimately leads on to metabolic syndrome. Talking in particularly about the liver, whenever we have ectopic fat deposition of the liver, there is hepatic insulin resistance, there is mitochondrial dysfunction, again more inflammatory cytokines, ultimately leading on to promoting insulin resistance, atherosclerosis, and systemic inflammations. All said and done, this ectopic fat that we are talking about is in the wrong place, a place like liver, and it promotes all these inflammatory problems. So, are we actually different with respect to the ectopic fat that we have, and does that actually explain some of these studies that we saw that have much more risk of metabolic problems in Asians as compared to the West? This This hypothesis first came back way back in 2007. This was the post-tissue overflow hypothesis, wherein whenever the subcutaneous fat is overwhelmed, the fat tends to reach out to other organs, and that's when it causes these inflammatory problems. This hypothesis was later taken up as a study and published, and what it found was very clear that we Indians have much less superficial subcutaneous fat and much more adipose tissue, which is visceral or deep subcutaneous, and that is really responsible for our increased prevalence of these metabolic problems such as low BMI. So all said and done, ectopic fat is bad, ectopic fat causes metabolic problems, Indians have less subcutaneous fat, more visceral fat, but how does it affect to us as clinicians? So how do we assess this fat? So we could assess ectopic fat in the liver, which could be either by a non-invasive test. So there are some non-invasive tests which are mainly used in epidemiological studies, where again we do not have radiology available at local villages, and these are some of the misses. They have a sensitivity specificity of around 80 to 90%, but what is commonly used in practice is something like an ultrasound, where we compare the hyperintensity of the liver with the kidney and compare as to how much of the fat, and we can grade it and tell the severity of fatty liver that we have. We can add on to that, use a fibroscan, and that's essentially how to use and detect fibrosis and see the liver stiffness, and there are several indices that are present, and that help us detect how much is the fibrotic component of this liver fat. More high-tech imaging like CT abdomen and MRI, they are expensive, not commonly present, and have more radiation exposure, and that limits its use. Definitely they have more sensitivity and specificity to detect any of these fat. We've also used MR spectroscopy, but again this has more radiation exposure, and this is more towards research setting rather than in day-to-day practice. When we have to go for a biopsy, it's only when we are trying to actually predict how much of ash is there, because clinically it's sometimes very difficult to detect, or clinically even radiologically sometimes it's difficult to predict the exact amount of information that is present in ash, or when we have to rule out other causes of chronic liver disease. So all said and done, of the different modalities, the most common one that we often use in clinical practice is ultrasound, and obviously the sensitivity specificity does for higher types of imaging, but that does not really come into practice in day-to-day practice because of the higher radiation, the cost, and the limited availability. So why is ectopic fat really bad, especially in the liver? What are its consequences? And definitely ectopic fat has been shown to cause more incident CVD, there is more metabolic problems, but the most important thing that has been shown is the mortality. And when it has been shown that whenever there is more fatty liver, there is definitely twice as more as mortality in our patients who have this fatty liver. And that's why it's important for us as clinicians to take these patients seriously. A patient with a fatty liver, no matter the same BMI, no matter the same age and sex, but if that fatty liver is present, that needs to be addressed, because that is ultimately leading on to more deaths, which is either because of cardiovascular disease or other related causes. We have data that has shown that whenever this subcutaneous fat is restored in animals, it tends to reduce this insulin resistance and improve their metabolic profile. But nutritional counseling is also shown to be very effective, and it does reduce fatty liver. So we cannot just bypass the lifestyle changes. It's important to address the nutritional aspect as well. It has gone up to this extent. Professor Roy Taylor's a lot of work in reversing this twin cycle of diabetes, and actually reversing what bariatric surgery does by nutrition alone, tend to reverse the entire process of getting somebody who's diabetic to bring back to normal glycemic levels. Other medications, so other medications that we use would be insulin sensitizers. Unfortunately, metformin has not been that great to reduce the liver fat. More and more data is available today that it does not change, even though it improves insulin resistance, it does not change so much liver fat. Pioglitazone is slightly better, but then most of the studies which have used pioglitazone actually non-diabetic subjects, and the current evidence is to use magnetizone in non-diabetics and with biopsy-proven NASH. Vitamin E has been used and has shown to again reduce the prevalence of NASH, again only in biopsy-proven patients or those who have no diabetes. Other things like UTC or statins are actually not really beneficial again for reducing liver fat. Pediatric surgery, we know, improves diabetes. There is long-term data available even for fatty liver disease, though just fatty liver disease per se is not an indication for pediatric surgery, but if the patient has other indications, it does help, and long-term data shows that overall the steatosis, the inflammation is less on long-term. To sum it all up, we saw what is ectopic fat, why is it formed, and then how it consequently ultimately leads on to increase prevalence of metabolic syndrome and the metabolic parameters there. I come back to these two patients which I started in the beginning. My patient 1 was a 37-year-old lady, morbidly obese, but with borderline metabolic problems. In my patient 2, almost the same BMI and age, but florid metabolic complications. We saw that the visceral adipose tissue in patient 2 was much more, and patient 1 was much less. And how I managed it was that the patient 2 was affordable and willing for pediatric surgery, and that's what she is planned for. And patient 1 was started on intensive lifestyle modification. We started meal replacement therapy and medical management for reducing the weight. So this I come to an end. We'll take questions at the end.